It's now my pleasure to introduce our first panel for what provides to be a very thought-provoking presentation. The opioid crisis is America's #1 public health emergency. Given the complexity and severity of the crisis and the layers of society that it impacts, its costs to us are great, both in terms of dollars and fundamental humanity. We're going to have to work together, providers, parents, pharma, advocacy groups, to make headway in solving this horrific problem. Before I introduce the panelists and invite them to come to the stage, I would like to invite our County Executive, Rob Astorino, to say a few words. As many of you know, the County Executive has recently launched a county-wide program focused on this growing addiction crisis. Please welcome Westchester County Executive, Rob Astorino.
Thank you. Good morning. First of all, how many sleepy but happy Yankee fans are there today? All right, good, good. I sense some Mets fans here. Billy, thank you very much, and to the County Association, thanks for letting me just talk a moment about Project Worthy, which is the county's response to the heroin and opioid addiction and crisis right now that are plaguing a lot of our communities. And I'm grateful for the panelists who are going to be up here as well. You know, it is a stark reality here in this county, like communities all over New York and indeed the United States, that we are facing a very lethal enemy that grows deadlier by the day. And it doesn't matter where in Westchester you are as well, whether it's our inner cities, whether it's our very rural areas, or certainly every school district, we are dealing with a crisis. And the fight is a strong one. It is a vicious enemy. But we do something called Project Worthy. It's Westchester Opioid Response Teams Helping You. That's what it stands for. Now, for me, this is a very personal issue. We have known, my wife and I, 3 people who have died of overdoses in the last 6 months, including one of my long-term friends that I worked with, both he and his wife, for many, many years, and their 22-year-old daughter, Shayna, overdosed, living in northern Westchester. Great kid for her entire life until about 1.5 years ago, she met the wrong person. And things spiraled quickly out of control, and she ended up dying in Florida. And so there are too many of these stories everywhere in Westchester. And so we have to figure out what to do about it, just like you're going to hear from in the panelists. Now, the harm, unfortunately, is coming from abroad. It is coming and flooding our streets from China and Mexico and Canada. And it's not heroin anymore. This stuff is laced with fentanyl, which is 50 to 100 times stronger than morphine, if you could imagine that. Our police department, they have to wear rubber gloves now when they go on these calls. 2 grains, imagine 2 grains of sand, if touched on the skin, could cause an overdose death for a first responder. So imagine what that's doing to the person injecting that. So the message is that we're not going to stand by idly and let this deadly trend continue. So it's why we created Project Worthy. Now, with respect to law enforcement, the county's Department of Public Safety is working hand in hand with our district attorney, as well as all of our local police departments. In July, we launched a local task force that is coordinating our resources through every step of the way, gathering intelligence, making arrests, and prosecuting criminals, and adding on charges if a drug dealer has sold something that has led to the death of somebody. And it doesn't stop there, because Project Worthy focuses on the root causes, the treatment and the rehab as well. So 4 fundamental blocks: education, and that's informing the public about the scope and the causes and the consequences of the problem; prevention, which is understanding the pain points, physical and emotional, that lead to addiction; integration, which is coordinating resources to produce the most effective response at hand; and action, and that's involving everybody with a stake in the outcome, and sooner or not later. So we're blessed, thankfully, in this county with an abundance of resource. So our approach is to break down these silos that always crop up, which will hopefully deliver practical and effective and lasting solutions. So we're building up response teams, including our health and mental health department, as well as law enforcement. but also reaching out to coaches and clergy and parents and everybody in the community, including and especially the business community, to get involved. So we have two important roles. First, Project Worthy and our teams are available to respond to those who are actually suffering from addiction and their families. And I guarantee you, and I'm not asking you to raise your hand, I guarantee you there are people in this room right now that are either quietly suffering from addiction or dealing with it in their family, unquestionably. Second, available they will be to conduct informational forums everywhere, including in your offices, at church, at our temples and mosques, at civic associations, and I ask you to do that and take us up on that. We got to spot the warning signs, and they're easy to detect in some cases, not so easy in others. Also learn the mental health causes of addiction, such as depression, pain management, anxiety. We're seeing with kids at school, when they get injured, doctors are overprescribing. Kids also going into medicine cabinets at your house. Please, when you go home today, check to see what unfilled or unused prescriptions that you have and get rid of them if you no longer need them. And we also, of course, developing strategies to preempt and address addiction. With us, and I think Michael Orth is here. Michael, yes, the acting commissioner of our Department of Community Mental Health, our commissioner for the Department of Health, Shirlita Amler, and George Longworth, our commissioner of our police. And I'll leave you with one note. We're also having a big summit on Monday at the county center. We have 300 kids coming from local schools, including private schools, that we're going to address all the issues that they have to deal with and suggestions on how to deal with the opioid addiction and how to say no, but also get their feedback and leave them with ideas that they can bring back to their individual schools to create not only a conversation, but some sort of action plan. So Teddy Roosevelt said, the worst thing that we can do is nothing. We're not doing nothing. We're doing something. And by you being here today, you also are doing something. So I thank you very much for taking time. I thank the County Association for allowing me to say a couple of words. And God bless you all for taking this cause up. Thank you.
Thank you, Rob. I would like now to ask the panelists who will talk about the opioid crisis to please make their way to the stage as I introduce Kathleen O'Connor, who will moderate this stellar panel. Kathleen is responsible for public policy and regulatory affairs for Shatterproof, a national non-for-profit organization dedicated to ending the opioid addiction. And Kathleen, on a personal note, I want to thank you for dedicating your life to a cause such as this. We have too few of you. With that said, welcome Kathleen O'Connor.
Good morning, everyone, and thank you first to our county executive, who I think had to exit, and to the Westchester County Association and all of you for being here. Bill, I am just one humble servant. We need every one of you to continue to be soldiers against this opiate epidemic. It is devastating, and the numbers, continue to astound each and every one of us on the front lines. We see in Westchester County alone, you've had a 200% increase in opiate overdose deaths. I don't have to tell the commissioner and all of the esteemed elected and appointed individuals in this room that, having the business community paying attention to this crisis, focusing on this as a public health emergency, notwithstanding the fact that the president has yet to do that, but really is a critical component to combating and really saving lives on a daily basis. I became involved in the work with Shatterproof, which is you can see our website is up there. This panel decided to do a roundtable discussion, so we don't have a ton of PowerPoint slides, but I put that up there just to show you. Shatterproof is a national organization that's been committed for the last 5 years to helping states combat the opiate epidemic through basically through advocacy legislation, and we've been very involved on the federal level in the CARA Act and as well as on the repeal of the Affordable Health Care Act, which would really be devastating to those individuals who are working on their treatment and recovery. And so in my house, we refer to moderators as kind of like corpse at an Irish rake. You need to have one, but nobody really cares who it is. So I'm just going to say enough about me, but I would encourage you all to take a look at the great work that Shatterproof is doing around the country. We've been in 23 states working on everything from prevention, treatment, recovery, and access to health care. We've actually passed laws in 23 states on prescription drug monitoring programs, naloxone, and Good Samaritan laws, and we're working this year, really focused this year on treatment and recovery resources for those in need, because that's really probably the fastest and the most growing demand in the space is both, obviously, Stephanie's going to talk a lot about the prevention piece, but really, and then we'll talk about treatment and recovery. So without further ado, why don't we go this way? So we will start, I will let all of our esteemed panelists introduce themselves, and then we'll let the panelists are going to give kind of a few minutes of what they're working on in this space, and then we'll let everybody speak for 5 minutes, and then we'll start taking and asking questions. So why don't we start with you, Mark, from Pfizer. I'll let you introduce yourself.
Sure. I'm Mark O'Neill. I'm the marketing director for Pfizer's abuse deterrent opioids portfolio. So I really appreciate you having us here today. We're going to share some insights on how we're approaching the epidemic.
I'm John Avery. I'm the Director of Addiction Psychiatry at NewYork-Presbytarian Hospital and Weill Cornell Medical College. Happy to be here and to discuss these things as well. My research focuses on stigma and treating co-occurring disorders, and I'll talk a little bit about that in a minute.
Good morning, everyone. My name is Dr. Steve Ferrando. Like John, I'm a psychiatrist. I'm the Director of Psychiatry at Westchester Medical Center and the Chairman of Psychiatry at New York Medical College. For the entirety of my career, I've been involved very much in attempting to treat co-occurring medical substance use and mental health disorders in integrated, innovative systems of care, and I look forward to speaking with you about my thoughts about it and contributing to the panel.
And I'm Stephanie Marquesano. I founded an organization called the Harris Project, and I'm very excited to be here. This is actually my first corporate panel, and I'm very excited that the Westchester County Association chose to include me. I'll be telling the story from the parent perspective. My own son died of an accidental overdose. He had co-occurring disorders. The Harris Project is the only nonprofit in the nation that addresses the needs of people with co-occurring disorders, and I'm really excited to be able to share that this is an innovation program. There is so much innovation going on right now in Westchester specifically that I'm very excited to share where you can be a part of this.
Thank you. Did I turn that off? Why don't we get started? Mark, why don't you tell our business leaders and community people here kind of what you're working on at Pfizer and what you're seeing in this space?
Sure. Do you want me to stay here, Kathleen, or stand up? So my name is Mark O'Neill. I'm a marketing director at Pfizer on the abuse deterrent opioids portfolio. When people hear marketing, right, they immediately, I think, believe it's creative content, television ads, but marketing is much more about analytics, right? Really deeply understanding a disease or an issue. So to help me with analytics, I often use frameworks. And the one that I use often is problem solution, right? So, and B, you actually mentioned that a moment ago. So the thing with that framework is when you think about it, the solution to be effective has to map directly back to the biggest part of the problem to be effective, right? So, I'm going to ask you a question. I've asked this hundreds of times. How do you define the opioid epidemic? And you don't have to answer it, but just keep in mind the first thing you thought of when I asked you that, right? Because defining the problem is the key to success. So again, I've asked this hundreds of times, and I've gotten all kinds of responses. And that led us to a journey of discovery of two big insights that we believe would have a significant positive impact on the opioid crisis. So what we hear a lot of when we ask that question is doctor shopping, right? Like, abusers going from practice to practice, just scooping up prescriptions and then abusing them, right? So now if that's the problem, then PDMPs are a great solution. Those are those call centers that doctors call, like if I'm going to get a prescription, they call as Mark, has he gotten other prescriptions? No, then I get it, right? So what we've noticed is and I'm not dismissing PDMPs at all. Every solution is valuable, and it is circular. But what we found was that as these prescription drug monitoring programs took off and more states adopted them, the opioid epidemic kept going up. Right? So you can't ignore that fact. Like, you have to actually embrace that and understand what's going on here. And what we found was that when abusers abuse opioids, guess what percentage of time they get those pills from doctor shopping? 50%? 60? 3% of the time they get those pills from doctor shopping. Yet that is the most mentioned resource. By far, it is the most resourced solution that's out there, right? The National Task Force releases money, that's where it goes. Now, we looked into it a little bit deeper. The biggest source of opioids, like when a person is abusing opioids, the number one source is what Rob mentioned, diversion. 70% of the time, when somebody's abusing opioids, they get them from family or friends. 70. Right? So now we had to look at a different framework, right? I said problem solution was the first one I looked at, but we had to look into a different space, and I think it was economics, and just like you mentioned before, B, we looked at supply and demand, right? You have to look at the issue differently, right? So if you think of abusers as demand, you have to think about supply. Where are they getting the pills? They're getting them from us, right? From family or friends. We're giving them, selling them, or they're stealing them from us. So again, we had to think of it differently. A couple of other things we found. 2 to 4 out of 100 patients will become abusers. 1 out of 3 prescriptions will be abused. 1 out of 3. So clearly for us, the big takeaway was that there's always risk with abusers, but there is significant risk with the pills that are out there. And if that's the issue, we have to do something to dramatically reduce the number of pills in a clinically appropriate way. And we built a platform to do exactly that. And if I get time later, we'll talk about it. But when you think about 2 last data points, we are 5% of the world's population, the United States, 5%. We consume 80% of the world's opioid supply. That is so far out of balance. Just that alone should tell you that we cannot tweak our way out of this problem. We have to think about it differently. We are looking at it currently, supply and demand, but I would also argue we need to think about it like the technology thinks about hacking. Because PDMPs, right, they solve that doctor shopping to a great degree. But if we shut down what we believe are the biggest inappropriate pushing of pills into the communities, then it'll circle back there. Just like hackers are often 1 step ahead of the solution, a small group, and the rest follow, I believe it's the same with abusers. So I think it's going to take a holistic approach, and it is going to take some reactive steps today, some big, blunt, reactive steps to really address this problem, and some proactive steps to really extrapolate where they're going to go next and shut that down. So that's what we're working on at Pfizer, just really trying to get deep into this issue in ways that are maybe not intuitive and create solutions platforms that we can share with the healthcare community to have a positive impact on the epidemic. So that's what we're working on. Thank you.
Well done.
Yeah, go for it. Go ahead. Again, I'm John Avery. I'm the Director of Addiction Psychiatry at NewYork-Presbytarian and Cornell Medical Center. Every time I hear the numbers for the opiate epidemic, I'm always overwhelmed, and I talk about it all the time. People dying every 7 hours in New York City, the number of families impacted, and addiction in general. It impacts 1/3 to 2/3 of all families, and it's very humbling and sobering. At NewYork-Presbytarian, we've seen just a 3-fold increase in ER presentations in just the last year alone, and it's many times greater than it was 15 years ago. This week alone, I've seen in the emergency room 5 or 6 people come in with overdoses and have met with their families, and it's devastating. At the same time, I'm excited to be an addiction psychiatrist. I think it's an exciting time in the world of addiction. I think there are interesting medications. We know more and more about therapies that work. And I sort of feel like every physician should consider themselves an addiction provider, that they should be excited to take care of these patients. And unfortunately, that's not the case. Physicians especially, don't share my enthusiasm for taking care of patients with substance use disorders. In fact, among all the conditions in medicine, substance use is one of the only 2 conditions that attitudes from physicians are worse towards these patients. And not only that, attitudes get worse over time. So that medical students are sort of the most excited about taking care of patients with substance use disorders. And by the time you finish your training and get out into the field, when presumably you have more knowledge and skills to provide treatments, the attitudes decline. And that's really disturbing. We expect our senior physicians and our doctors to want to take care of these folks, to be compassionate, and unfortunately that's not the case. And there's a lot of reasons why. We still view it as a moral failing instead of a brain disease. You know, we're not exposed to people in recovery. There are 24 million plus people in recovery in the United States, when doctors may only see people that are actively using and may not be in touch with that group of individuals. And so, my push is really to make doctors, be excited, have them be excited about addiction, and to inform them about the different treatments. And we're sort of in a unique place in this opiate epidemic in that physicians are responsible in a lot of ways. We were overprescribing opiates. We're the ones that put them in the medicine cabinet, such that 70% of people that start end up, getting them there. And we now need to be the people that are offering treatment. It's not only that we gave opiates, but historically we don't screen people for addiction. We don't ask them how much they're drinking, how much they're using of other substances. And so there's been a real deficit in our ability to address our patients and their substance use disorders. And even when we identify a problem, we've tended to say historically, go to AA, or you should see someone about the substance use, rather than owning that problem as physicians. And so with the opiate epidemic, we're in a unique spot to sort of own the treatment of our patients, to pay attention to the prescription opiates we're prescribing to folks, but also to screen our patients and their family members for use, and then to offer them medication-assisted treatment. Opioid use disorder is unique in that relapse rates without medication-assisted treatment approach 100% if you're not on what's considered the gold standard treatments, which are buprenorphine, methadone, or Vivitrol. You, of course, have to address co-occurring disorders, which I'm very an advocate of, and address the medical comorbidities. But if you're not actively addressing the opioid use disorder and providing these treatments in our communities, if not all doctors are providing these, then we really don't do our patients a service. And especially now that people are transitioning to fentanyl, which is so much more potent, the risk of overdose if you're not on buprenorphine or methadone for these things is really high. And so the goal, I think New York City is doing well, Westchester is doing well, is to really increase the number of providers that can offer buprenorphine, increase physician awareness of how to get the license to prescribe it, how to get people into the medication-assisted treatment, and to really take ownership of this problem so that we can start making headway and decreasing these overdose numbers. So thank you.
I will try to be complementary to what others have said. 27 years ago, I finished my residency program. and I was interested in medical and psychiatric disorders and their co-occurrence. My first job was at San Francisco General Hospital. That's where I trained. And I took a job in a substance abuse treatment program. And what this program did was provide care for HIV-infected, opioid addicts on methadone maintenance, and took care of their medical, psychiatric, and substance abuse problems under one roof. Really, you know, this is not new, actually. We've mentioned many times today that, or there's a sense that there's a newness to this. We've actually gone through many waves of opioid epidemics over time. This is our modern version of it. I think the answer to addressing it, at least from a, from a medical care perspective, is really doing what people are mentioning here, is to really genuinely integrate care models. The siloing of care, the notion that people have to go to different places for their primary care, for their mental health care, for their substance use disorder treatment. This remains prevalent, and many among us are trying to change this and shift this. At Westchester Medical Center, you know, we have a footprint in 8 different counties. We have 10 hospitals. We have many addiction treatment programs. We've been very involved in the delivery system reform efforts. Much of what's being talked about is how we develop systems of care that can bring all of these things together in a meaningful way. John mentioned that providers really, even if they have a positive attitude and want to be able to help an individual with addiction, don't know how to talk to people. They don't know how to screen people. We talk about screening, but say somebody turns up positive on a screener, how do you talk to them? How do you motivate them to A, admit to and disclose that there's an issue, B, to accept help for it, and C, how do you then help them go to whatever program that might be helpful to them? How do you help them identify something that's viable? How do you help them disclose to family and friends or whatever? Or how do you help the family who comes to you who has identified someone in their family that has an issue, that has an opioid issue? How do you help them help their family member? Really, it's very well known. We're talking a lot about prescription of medications, coming from physicians and other professionals, nurse practitioners, others. There's a sense that those folks need to, in some ways, be able to help bridge the gap. And yet I think we have a really long way to go between sort of identifying a problem, sensing a problem, and really getting people where they need to go in terms of treatment. The other thing I would say, which is really, really huge, you do not say, or you do not see almost ever individuals with a pure opioid addiction or dependence or use disorder, depending on the terminology. There's almost always a co-occurring mental health disorder, mood disorders, anxiety disorders, ADHD. Many of these individuals are not just on opioids, they're on polypharmacy with other psychotropic drugs. Much of the danger from overdose not only comes from just using an opioid, but many times patients are using other medications, benzodiazepines, Valium derivative types drugs that also originate in pill form. So very, very complex to both address the mental health element of the problem and also the substance use element of the problem and the use of multiple substances. The last thing I would say really is that, you know, and I would agree very much with what John was alluding to. You know, we have a tremendous problem with stigma. You know, I've worked with HIV/AIDS patients for years, worked with hepatitis C patients. You know, these are disorders that interface, or these are medical issues that interface with mental health and addiction, you know, in a huge way. And stigma is a very big part of the lives of these individuals. So to admit to having an addiction issue, having a mental health disorder, needing to get treatment, especially among some of the communities that are now being affected by the opioid crisis, is a huge stigma. It's a huge blow to the individual, huge blow to the family. And if we do not address the stigma involved in this and the identification of these problems, we're in huge trouble as a society. I think in some ways we're enlightened, and in other ways we really have a huge, long way to go. Thank you.
So typically I use no notes when I'm in front of 1,000 high school students, but in this audience I feel the need to kind of have my cards with me. So I'm Stephanie Marquesano, and I started an organization called the Harris Project after my son died of an accidental overdose. He was 19, he died on October 23rd, 2013, and I launched the Harris Project at his funeral. My goal was to do things differently. So much of what parents do are what I refer to as one-and-done programs. They come in, they tell their story, and they leave. And for me, I knew that there was more going on than just that. I live in Ardsley, small town in Westchester, and when a 19-year-old dies, everybody wants to know, where do we make donations, what should we do? And I said, you know, Harris had something. It was called co-occurring disorders. And each and every program that he went into said that they addressed co-occurring disorders, but all of them failed on the mental health piece. Harris was diagnosed with an anxiety disorder when he was 3, with ADHD when he was in 8th grade, and the first substance that he turned to was marijuana for self-medication. Our approach really has stuck true to what we originally envisioned, which is we look at this from the two ends, prevention and the need for integrated treatment. And so that's what I'm going to talk to you a little bit right now, because Westchester, believe it or not, is leading the way. You wouldn't think so, because we're not really hearing about it on the news. On the news, what we hear about every single day are the tragedies, the numbers, the problems in Florida, where my son was. And I've been asked to participate in all of those things, and I'm like, you know what? It's enough talking about what doesn't work and what's going wrong. I'd like to start focusing on what we can be doing together. So over 10.2 million Americans have co-occurring disorders. They say that between 65 and 70% of all people misusing substances have co-occurring disorders. So when people go into treatment, think about it. Mental health, trauma, traumatic brain injury, if you're not looking at the whole person at the same time, and all you're doing is detoxing and taking away the substances, how do you expect them to sustain recovery when they get out? When people are incarcerated, and they're in prison and they come out and it starts again, and people are like, they were in jail, why isn't it working? Well, if you didn't treat the mental health issue, then they're going to go back to the behaviors that they knew. So our goal is twofold. One is to work with systems to integrate care. The other is to work with our young people on prevention. So immediately upon launching, I did the trip up to Albany, and I have to say I got frustrated very quickly because most of the advocacy was around more beds and longer treatment. And I would sit in rooms with people whose kids had been in rehab programs 10 times, 12 times, 15 times, and I'm like, more beds and longer treatment? What don't you get about the fact that maybe it's the model that's not working? And so I always say that I follow the breadcrumbs. Originally, what I needed to do, in my mind, because I have it on my PowerPoint slide for the kids, and research has a big line through it, because just like the doctor said, this is not new. I am in meetings with people who have been in this industry for a really long time, but I liken myself to, you know how like the truck is stuck under the bridge, and it's the little kid that says, just let out the air in the tires. I'm not a professional, but when I talk about this, everybody's like, yes, we talked about this before. Now it's time to start really doing it. So following the breadcrumbs led me to somebody named Dr. Ken Minkoff. He is a national expert in systems change for those with co-occurring disorders. I reached out to him because somebody connected me, and I got to him. And I emailed him, and he said, can you call me in 15 minutes? And I said, sure. He said, I've never spoken to a parent who so clearly understands what is wrong with the system. What can I do to help you? And I have to say that since our first conversation in February of 2016, I have spent hours on the phone with him. He was part of our first integration roundtable, which Michael Orth, who's here, moderated. 3 counties participated, student assistance services, hospitals, service providers, all around systems change. And anybody who knows me knows there is no such thing as a one and done with me. And so I kept it, what are we doing next? What's the next step? And Putnam and Westchester said, we're gonna bring Ken in and we're gonna do a forum. I said, great, time is ticking. Then I get elected to the Regional Planning Consortium, which is a state-mandated committee that looks at Medicaid reform and systems of care. And people are like, they only have the parents and the peers and the youth advocate on here to because they have to fill a slot. There's nothing that's really gonna come from that. And I was the newbie, and I said, you know what? It sounds like a good framework for me. I'm gonna start going. So I have to say, on November 13th and 14th, with Westchester leading the way, all 7 counties are bringing Dr. Minkoff in for a 2-day workshop called, and I'll tell you exactly what it's called because it's so amazing to me. It is called Creating a Welcoming and Integrated Trauma-Informed System for Addressing Those with Co-Occurring Disorders. So if you want to know what Westchester is doing regarding systems change, you can look right here. You can ask me anything, or Michael's here, to know what's going on with that. So my son had a path to substance use, right? He started with anxiety. He was seeing professionals. You see the kind of person I am. I'm an attorney. I was PTA president on the school board. Harris is a really good-looking kid, athletic. But what you might not know is that it took him an hour to get out of the house in the morning. And that wild energy you saw was just sort of that nervous energy of being out. Or that if there was an away soccer game, the stress that he would have about getting on that bus. And so the other thing was, I wanted to bring the conversation to young people. Feeling good in the moment and telling my story was not going to change anything. So we became strategic last year. We partnered with the Westchester County Department of Community Mental Health, Putnam Northern Westchester BOCES, Southern Westchester BOCES, and Student Assistance Services of Tarrytown. We named our movement CODA, Co-Occurring Disorder Awareness. And I am actually a Project Worthy Response team member, and I'm working with Michael on the curriculum for that huge event that's happening on Monday at the county center. If you want to know where you fit into this, you have a place. I haven't done any work in the corporate sector at all, haven't done much work with the hospitals. This is a labor of love, but there is a place for us all in there. Last year, we reached 16 high schools, with 37 schools now participating on Monday. I've done this on the original money that was donated to us when Harris died. And we literally want to embed this conversation in every school in Westchester. That takes all of us. There isn't one of us in this room, and now you all know me, so you certainly know me for sure who's experienced this, but in your personal lives, there is nobody missing from this conversation, and everybody has a place in it. So thank you so much for indulging me and letting me be part of the panel.
Well, is this working? Well, thank you all for sharing a little bit of what you're currently working on and your experience. I think all 4 speakers, and we heard it from the county executive as well, and I see it every day in the work that we do at Shatterproof around the country. I'd love the panelists' thoughts on how companies and community leaders can really lead on ending the stigma. You have stigma within your own profession. You have stigma in the schools. You have stigma in the business community. At Shatterproof, we do a lot of community engagement around ending the stigma. We always tell the story of our founder, Gary Mendel, who founded Shatterproof, lost one of his 4 children, took his own life out of shame and stigma after 10 years in and out of treatment and recovery systems. But he always says, and this is in, you know, Westport, Connecticut, where these children were raised in a, you know, very affluent, with all the resources in the world. You know, one child gets diagnosed in the community with cancer, and everyone is doing lemonade stands and fundraisers and dropping off casseroles. Another child the same age at 15 gets diagnosed with a co-occurring disorder, whether it's anxiety, which leads a pathway to substance use disorder and ultimately taking his own life. But nobody is talking about it. Nobody is accepting. And now the country has become quite a bit more. We're doing a lot of work with the U.S. Chamber of Commerce, and we have set up through Shatterproof has a toolkit for employers, which works on screening and supporting people in your companies that are trying to deal with either addiction and substance use disorders themselves or with family members who have it. But I'd be more interested in kind of hearing a little bit about what Pfizer thinks about that and what you on the front lines in the treatment community feel like this community at large that we're addressing today can be helpful on the stigma issue.
Sure. So
We'll go that way.
yeah, okay. So I think from our perspective, it's all about normalizing things. So a lot of diseases are visible and some are not. So so my first wife had schizophrenia and depression, and it was really hard for me at the time to get my head around, like I didn't know how to handle it because I couldn't see it. Like it wasn't tangible to me. But it was only later in life that I understood I was looking at it through the wrong filter. I was looking at it as if it were something physical, like an acute condition that could be fixed. If I saw it more like cardiovascular disease or cancer, I would have been much better off at that time. And I think when I started working at Pfizer, that's like sort of a foundational mindset there is all diseases are normal, and even the ones you can't see or touch are normal. And you just have to accept that. And the more you're open about those discussions and transparent about them, the more people around you become the same way. And I think it's something that at a corporate level, you know, it is institutionalized, but at an individual level, that is something we can all do. Like there's no judgment with a disease. If you can see it or not, there is no judgment. So.
Right, and I agree that even in our own families or in ourselves, when you use substances, you can view it as a moral failing. And I think having these conversations about addiction being a brain disease that has good treatments and that people can be in recovery from too. I think we need to hear stories of people that have, you know, accepted treatment and have gotten better. At times we focus on bad outcomes, but there's a lot we can do, and there's a lot of people that have had good outcomes. And part of the work that we're doing with physicians is we have these online modules that show people in recovery, speaking to physicians about their experience with them, and saying, look, I can get better. I'm interested in talking about it with you when I come to see you. You just need to ask and to offer these treatments. And people with substance use disorders are very fearful of finger wagging, that they're going to go tell someone what's going on and they're going to get that finger wagging approach. And even in addiction medicine, historically, if someone came to us, we'd be like, don't do that. What's wrong with you? I mean, you've got to stop right away. Whereas these days, and what happens when you finger wag at someone is they run the opposite direction. And so you really have to meet them with kindness, with the science, you know, to explore what they like about using, what they don't, what role it's playing in their life, and then to direct them to the treatment that they can feel motivated for and can feel like the right fit.
I react to the discussion both as a parent of two 17-year-olds who you know, are exposed to a world of stress, looking at college, the normalization of sex, drugs, and rock and roll on social media. And sometimes it feels, you know, overwhelming, and I feel like I'm the finger wagger in chief at home, not practicing what I preach professionally. It's very, very difficult, I think, to, in the moment, translate what we regard as all of our knowledge and understanding into an interaction with an individual that will help them. I think I agree that talking about it, desensitizing ourselves to the kind of notion that this is a shameful problem. You know, it's prevalent, it touches everyone. I think, you know, I thoroughly agree. Wherever I go speaking about this, you know, everybody knows somebody or has direct experience. So despite that, you know, and despite how enlightened we may be, I think the opioid problem and other, you know, substance use disorder problems, it sort of de-skills us in the moment. And sometimes because of resistance of an individual or whatever, you just don't know how to respond and you don't know how to take that next step. So I think it's really, really important that we be open, we educate as much as we can in industry, obviously, you know, both provide education and services to employees because inevitably in themselves or their families, they're going to have somebody that needs help. And I think expressing that degree of openness, people will come for help. Often it is families. I mean, you know, so often it is families because the individual who's mired in the addiction in the moment often, you know, can't access help. And the other thing is to sort of help people recognize signs, you know, that lots of times medical comorbidities are signs, you know, that the individual isn't really talking about it, but you can see stuff happening. You know, you see medical consequences, recurrent medical problems, infections, things that don't make sense. And I think those are the kinds of things that it's helpful to be aware of, because unfortunately, a lot of times people really don't get into treatment until something really bad has happened. And hopefully that really bad thing will certainly not be an overdose death, but there's lots of other morbidities short of that that can be very devastating to an individual. So there's lots of degrees of recognition, but again, just emphasizing really talking to kids, being open and non-judgmental, that's really, really big. It's just practicing it in the moment when you have the opportunity. That's the challenge.
So I guess I'm going to call myself the anti-end stigma person. It's what I typically talk about when I'm with the high school audience. My view is that if you have to end stigma in order to start talking about how you're feeling, you're taking a step that's almost wasted. My goal is to get young people in particular to start talking about how they're feeling. If you're a young person who has seasonal affective disorder and it's hard for you to get out of bed in the morning in the winter, being able to talk to a teacher about that, being able to share with your friends how difficult it might be for you to walk in through the thresholds of that school is the first step in making change. Because when you look at this co-occurring disorder piece, particularly for our young people, 1 in 4 to 1 in 5 of our young people have a mental health issue with severe impact in a given year. 50% the age of onset is 14, 75% the age is 24. They are in the crosshairs because experimentation is viewed in society by some people as a rite of passage. So they don't really see the steps before. And then on the flip side, let's say you have an athlete. They get a catastrophic injury. Now they're not practicing with their team. They're more isolated. Maybe they were given a legal prescription for medication, but nobody really thinks about how they're feeling. And so with a lot of what we're doing, particularly with the curriculum that we developed for Monday, is to really empower young people to start talking. Not to end something, but to be genuine, to be their true selves. The first activity we're doing is, what do people hide behind their masks? And the goal of the day is to really create opportunities for them to create communities that care. Let down that guard and start talking. And if it takes the adult world a little longer to get there, I'll do as many community programs as need happen so that the adults in the community start recognizing for them too, being able to talk about what your individual struggle is takes away the secrecy. It makes it less likely that you're going to use substances because you're sharing, because you're getting referred to the right people before substance use starts.
Thank you. Great insight and perspective, and I do really commend you for the prevention work at the earliest levels, and I do think you're absolutely right. What we see around the country, and we've done focus groups and polling about how to change the language related to substance use disorders and stigma, and you do see that the older the generation is, the harder the perception really is to change, to start talking about it as a disease without judgment. And so that's a very helpful perspective. You can't open up a newspaper without seeing a front page headline, not just about the overdose and the opiate epidemic. I think when in our conversations that we've had with the federal government, both at law enforcement and HHS, the next wave of this opiate epidemic really is going to be the stimulants and the co-occurrence of the benzo and opiate. I mean, I think when we were in California doing a lot of advocacy work, the ER doctors came to testify in Sacramento in support of a piece of legislation requiring doctors to check the prescription drug monitoring program before they prescribe. The ER doctors testified that 3 out of 4 of the overdose incidents that are presenting at emergency rooms in California were the co-prescribing of the benzos and the opiates. So I think we also need to do a better job kind of educating both the business community and the providers on that co-prescribing and that epidemic. Switching gears for a minute, the other reason I started on the front page of the paper was because it was just yesterday, another news story about state action against the distributors, the manufacturers, so lawsuits that are being brought around the country. In September, the last time I counted, there had been 27, including 3 Native American tribes who were suing manufacturers, distributors, pharmaceutical companies. So that's, that's all pharma, CVS, McKesson, Cardinal Health, everybody in the chain is being sued. And I'd be interested, Mark, kind of on your thoughts, as we all in this room remember pretty well, I think the settlements that came out of the tobacco cases and what was kind of done with some of those resources and the changes. If you look at what happened, if anyone follows the Truth Initiative to see what they have done on the PR campaign on smoking, you've seen such a rapid decline in smoking in the country in a short period of time. I'd be interested, Mark, to hear what Pfizer has. I know you guys have been involved in some of these suits, and I'd be interested in kind of your thoughts on that.
Yeah, sure. So that's a fact, right? That is happening. I would say, I think a couple of weeks ago, 41 attorneys general got together and sued. I think there are, historically, there's been 5 pharma companies that are included in almost all of them. Pfizer is not one of them. And last year, the city of Chicago sued a bunch of firms, and they purposely mentioned that we set the standard, not in these exact words, but for responsible sales and marketing of opioids. And I think I can't speak to those companies, what they do. I only know what we do. And I think it starts with our culture. So we have a motto. I don't think this is like public so much, but patients first. So not profit first, patients first. We have a belief that if everything we do is seen through that filter, that good things will come, value will come our way. And I'll give you 2 or 3 examples in the opioid space, what that meant for us. So we found these 2 significant insights as to how opioids were just flooding the market. Like today, 500,000 opioid prescriptions will be written, like released into our communities, right? And we found ways where that was inappropriate. So I found these insights, I brought them to the president of the company. Now, first thing he said was, how are you gonna get this message out, right? Like what, and then the second question was, what do you need? So now that's a patient-first mentality. A profit-first mentality would have been something like, what's this gonna do for our business? We make pills, and you're telling me you found insights where we need to reduce the number of pills. So you can see kind of even at the highest level how that mindset like manifests itself. Another thing is sales reps, pharma reps. Some get incented to grow a market, just more volume. So we incent in this space to convert patients from non-abuse deterrent opioids to abuse deterrent opioids. We believe in that technology, and we believe it is the best solution we have today. Better technologies are coming, but today, with diversion being what it is, that's something to think about. So we even incent our reps differently. And final thought is, like in our, at Pfizer, we're sort of organized around medicines, diseases and medicines. And we try to do thought experiments. So at every meeting, we imagine that a patient is in that meeting. So not a Pfizer person, but somebody like you sitting there. That changes the tone of the entire meeting, and that's every meeting. So you can imagine how, and we do this every week, right? So you can imagine how that weaves its way into the culture. And I believe it's things like that that separate us and allow us to be at venues like this. So
interesting. I completely forgot we were supposed to take questions from the audience as well. So you guys can be thinking of any questions that you all might have for any of our panelists here. I direct one, not, oh, I see a hand.
There's somebody over there.
We've got a question. I just hope it's not for me.
I hope it is.
For any of you, do you have any comments on the growing decriminalization of marijuana around the country and how it affects the opioid situation?
I can add a perspective. I spend a lot of time working in the emergency room. I know my colleague does here. And want to mention this and also cigarette smoking, actually, because it gets to the issue of mental health disorders. Cigarette smoking is still epidemic among individuals who have psychiatric mental health disorders. So it's a subset of the population that still struggles with tobacco. Likewise, marijuana, it is amazing how many individuals present for psychiatric consultations in the emergency room. Marijuana is almost ubiquitous in their toxicology screening. Almost ubiquitous. I mean, it's every time, and we all comment on this. And there's this notion that it's sort of normal and should be. I mean, there's all sorts of facets of this, but there's tremendous risk, I believe, associated in vulnerable individuals. I think of it as vulnerability. If you have vulnerability, both genetic and psychosocially, to a mental health disorder. If you have vulnerability genetically to a addiction problem, really the confluence of those things, when you then, sort of normalize marijuana, et cetera, it can be problematic. And sometimes we don't know who's vulnerable ahead of time, and certainly people don't identify themselves as vulnerable. So you talk about the vulnerability, the notion of self-medication, the notion of normalizing. From my perspective, in vulnerable individuals, it can be a very big problem, at a minimum. In that subset of individuals.
Yeah, I agree. I don't think you should arrest everyone with a marijuana use disorder. They should be, say, diverted for treatment. I think the risk of decriminalization is that we know in the addiction world that as perceived harm of a substance goes down, that use always goes up. And so the worry about the perceived harm of marijuana going down is that our vulnerable patients will use it, our adolescents will use it. We know if you start smoking marijuana before the age of 18, you're twice as likely to develop a marijuana use disorder, for example. And that can lead to co-occurring psychiatric and medical consequences. And some people want to make the debate sort of opiates or marijuana. Like, if we legalize marijuana, then the opiate use will go down. But it's not an either-or thing. It's not either opiates or marijuana. There's a menu of options to address pain. And so I think when people get into that opioids or marijuana debate. I think that's a false debate. I think there's potentially a range of good options to treat pain and psychiatric disorders and that sort of thing.
The only thing I want to add is, when I'm speaking to young people, the whole world of medical marijuana already kind of gives them the vibe that maybe it's not so bad. And what I always share with them is, even if, it's like, who am I talking to? Well, I'm not just talking to kids who are going to develop a mental health disorder. I'm talking to kids who are potentially at risk just because their brains are still developing. So really focusing with them on the fact that even if it became legalized, your brain is still developing until you're 25, and that if you really and truly look at what I'm telling you and back up the information and do your own research, the answers are clear. So it's not like the same way it's not opioids or marijuana, it's not alcohol or marijuana. And when I speak to communities, I say, I am not judging you as parents. I'm not judging your choices. You're over the legal age. I will judge you if you think your child needs to practice drinking or smoking marijuana before they get to college, because that only increases the chances that they're going to be doing more of that when they get there. You don't need to practice. And for young people, it's not a when or if it's going to get legalized. It's that for you, it really doesn't matter because your brain is developing. And if it's you and you have a genetic family history of addiction, if there are things going on, you may always say no for always and forever. And learning how to feel comfortable in your own skin, creating a generation of kids who can do that, who can go to parties and socialize, and if they don't feel okay, getting help for that as opposed to using substances to mask it, that's how you change a generation.
Hi, Patricia Kaliak from Greenwich Hospital and Westmed Medical Group. I just want to make a comment and a question. In a room full of doctors and hospital administrators, it's certainly hard to highlight the fact that this is our problem. As the addiction rates, we speak about how we have to improve treatment, but the addiction rates are directly related to our level of prescribing. They've gone up with our level of prescribing. So the question is, what are we doing as hospitals and hospital administrators, doctors, to prevent that? I just listened to a study done at Yale where they looked at the use of IV morphine versus subcutaneous morphine, and the fact that when you don't peak the IV morphine to the inpatient for post-op pain control, and yet you give it at a more level with subcutaneous, you decrease the amount of morphine used in that stay. We're using multimodal responses to post-op pain in our for our C-sections. I'm an obstetrician. We don't send anybody home on narcotics practically. I mean, I've written maybe 3 prescriptions this year for narcotics following a cesarean section. That is a significant change from 3 years ago before we started multimodal, which means the use of Toradol, IV Tylenol, and Motrin. So the question to the audience and to our panel is, are these programs in your institutions? Because the root cause of the problem is not only our societal issues with addiction, it is our physicians using opioids as our first response to pain. That's it.
Yeah, at New-York-Presbytarian Hospital, we have a couple initiatives around opiate prescribing and both in prevention and identifying people that have risky prescribing patterns. I think there's a number of initiatives to, if patients need opiates, to, provide them only on the short run, 3 to 7 days if they're leaving the hospital, and post-op to, provide non-opiate treatments first and then progress to opiate treatments only as needed. And the only way to make that happen across the hospital system is that we have protocols around it, we have monitoring, and the prevention piece is almost the easier piece. The more challenging piece in some ways is what to do with the folks with non-cancer chronic pain that have been on opiates for 10 years and on high-dose opiates, and what do you do with these folks? And we have a little team at New-York-Presbytarian of myself, a pain specialist, and we provide them data on their prescribing patterns, and we sort of talk, it's sort of like a consult service where we go to these providers that are giving out a bunch of opiates, let them know what the treatment options are for their patients, let them know how to taper, how to transition people to buprenorphine if necessary, and also how to counsel them on the risk toward their family members and all sorts of things like that. And there are sort of initiatives to have this consult team at different parts around the New York-Presbytarian Hospital system.
Yeah, we too are developing such a program as well at the medical center, and I think that it is true. I think that one thing that also strikes me is that somehow we've made the leap in our heads, and part of this, you know, the whole overprescription thing, having lived through, you know, this more recent rise, really for me comes out of kind of an overreaction or too much of a good thing. In other words, there in the 80s and 90s, there was literature that in this country we were under-treating pain. And this related to particularly patients with cancer, and the notion that, you know, John mentions this non-cancer pain, right? But a lot of this was triggered because there was medical research indicating we were not recognizing and treating pain. The problem came, I think you were alluding to it, is that there was an assumption that if people should not be in any pain, right? In fact, our regulators, when they come, you know, to the hospitals and survey the hospitals, we're required to ask about pain, and then we're required to indicate what we're doing about the pain. So at what level of pain do you say, you know, well, this is usual and it will last this long? At what level do you prescribe medication? And then when do you go to an opiate? And so it's become sort of this cultural sense that we're not supposed to have any pain. And this is a culture within the hospital. It's sort of, you know, pain is the enemy. You have to ask about it. You have to do something about it. And I think it's been reinforced in many, many ways. And we've jumped to the notion of using opiates. The other thing I think that's still prevalent, you know, if you watch the Yankees game, everybody was watching it. There's a commercial that I saw about the treatment of opioid-induced constipation with the acronym OIC. Who's ever heard of this, right? So there's some guy that certainly doesn't look like he has cancer up on the screen talking about treatment of his OIC with this drug. Implicit in that is chronicity, right? The notion that this seemingly functional-looking guy needs a medication to treat the constipation from his chronic opioid use. There's a lot of implicit messages in there, and I think, you know, we as physicians, healthcare professionals, hospitals, are responding to all of these different pressures. So, you know, it's really interesting. It's actually shocking to me to still see an ad like that on television. But we're all, I think, probably most of us have seen it if you watch, you know, mainstream TV and don't watch Netflix. But
and part of our prevention work in this is to really, we actually did a program at Greenwich High School. There was an orthopedic surgeon on the panel. It was about athletes, injury, addiction, and recovery. And part of it is also educating the consumers to know what questions to ask and to really inform parents, particularly if their kid has a sports injury, if they're getting their wisdom teeth removed. Part of it is, yes, the medical profession needs to get where they need to be, but if at the same time we can also be educating regular people about the potential risks, that's another opportunity.
So a couple of things we found that are to build on what they said. So opioids should never, with rare exceptions, they should never be written first line for chronic pain. So in medicine, right, you have these levels of treatment: first line, second line, third line. First line is what the medicine you give them first. We looked at 15 guidelines. None of them recommended an opioid first line. So then we looked at, okay, let's look at the chronic conditions for which, or the conditions for which opioids are written first line upon initial diagnosis. So something like joint pain or back pain, you should never get an opioid right out of the gates upon initial diagnosis. 56% of patients get an opioid first line. Like, that is wrong. That is clinically inappropriate. It's wrong, and it's part of what's feeding, you know, the prescriptions into our communities. The other thing we found was you have immediate release and extended release, two types of opioids, IR and ER. IR is for pain short-term, directionally less than 3 months. ER is for long-term, right? Pain longer than, chronic pain, longer than 3 months. We found that patients on IR, 83% were on it for more than 3 months. The average length of time was 10 to 12 months. So why is that important? Because each IR prescription is 4 to 6 pills. If you clinically appropriately migrate them to ER, it's 1 to 2 pills. So you could suck out half or 2/3 of the pills from the community just by migrating them to the right therapy. And that, it's not just the pills, it's the opportunity for diversion. So those are the two areas that Pfizer is focused on as far as reducing the number of pills that are flooding out there every day. So.
All good points. I understand we have 2 more questions.
Yeah, thank you. Dan Blum from Phelps Hospital, Northwell Health. I have more of an observation and a comment rather than so much of a question. We talked a little bit about personal accountability and also stigmatization. Certainly personal accountability on the part of healthcare providers. And I'm sure in the minds of some, there's the question of where's the personal accountability on the part of the person who has a substance use disorder. All patients, I think, have elements of personal accountability. I heard the term used, substance use disorder. I heard the term used addiction. I also heard the term used abuser. And I think that that's an inappropriate use of a classification. There was a point in time when we used to blame cancer patients or AIDS patients for their conditions. And I think that we need to rethink some of the terminology that we use. So I would urge that we do not use the term abuser. Thank you.
My question is a simple one. The doctor stole some of the question already. My wife and I will occasionally sit down to watch a television show. So a 1-hour show is about 40 minutes long with 20 minutes of commercials. The preponderance of those commercials are medical commercials. This kind of drug for this kind of drug for that. Is there any correlation between all of that bombardment of commercials about fixing it with a pill to where we are seeing ourselves go with this opioid problem?
So one, opioid medicines are not allowed, opioids are not allowed to be advertised on television. Apparently, I guess opioid, I'm unfamiliar with that, but that medicine apparently is. It's a constipation medicine, I guess, right, first and foremost. But opioids are not allowed to be advertised to consumers. So I don't know if that helps.
Right.
You just simply hear medicine, a pill for everything.
Well, as a prescriber, patients come to me all the time and tell me what I should give them. My kids do it too.
I'm almost worried about the 40 minutes of television too. I mean, they tend to glamorize addiction. They sort of view interventionalist type approaches as the go-to way to address substance use disorders in families. And there's not really good depictions of what it means to have a use disorder and how to seek treatment, in my opinion.
It's actually one of the activities that we're doing with high school students that they're going to be bringing into the middle schools once we have these leadership teams set up, particularly around things like vaping. So many of those advertisements now are geared towards middle school kids, the flavors, the scents. So part of it is going to literally be ripping advertisements out of magazines, finding things online, and looking at what the intended audience is and what the potential harm is. So I think that all of those teachable moments, as adults, we see it, maybe it goes in one ear and out the other, we're not necessarily swayed, but for a young person who's watching a show, that may very well happen. So those kinds of conversations are ones that you can really have like around the dinner table about things like that.
Absolutely. Well, we have overstayed our welcome up here. We appreciate each and every one of you giving us your time and your attention and hopefully your resources to help combat this scourge and epidemic. So thank you so much.